Okay, perfect. Okay, so in this presentation, I will be talking about the physiologic approach to neonatal shock. I will be focusing in this presentation on the clinical assessment of shock. I will not be talking about the advanced assessment or target neonatal echo. So this presentation is just focused on the clinical assessment, but the clinical assessment physiologic based. So I have nothing to disclose in this presentation, and I have 4 main objectives to discuss over the next 30 minutes. First, I will demonstrate the basics of blood pressure and the hemodynamics physiology. I will demonstrate the physiologic categories of shock. And then I will demonstrate the logical selection of cardiovascular support based on the physiologic categories of shock. So how to select the medication, not just empirical selection, one medication to fit everyone, no, the medication to fit the underlying physiology. And then I have some case scenarios for discussion. We know from the literature for the last 30 years or 40 years that we have some interventions that might be bad for outcomes. So we have to avoid them as much as we can, and we have to limit use of these interventions and use all of these interventions under certain clear guidelines. We know that oxygen therapy is bad for outcome. Mechanical ventilation, that's why we have to avoid mechanical ventilation and use more liberal CPAP. Antibiotics, for no good reason or no indication, is bad for outcome. Keeping infants for MPO, and we know that from the great presentation from Charla, that keeping MPO without a good reason is bad for outcome. And today, our talk about cardiovascular drugs. Using cardiovascular drugs might be associated with bad outcomes if you are using these drugs without very specific indication for a short period of time. At the same time, we have other interventions that can be associated with good outcomes, including breast milk or feeding, delayed cord clamping, skin to skin or kangaroo care. So that might help to transmit the flora from the skin of the mother to our babies. So encourage kangaroo care as long as tolerated every day. We know that CPAP or caffeine for premature infants, both of them are good for outcomes. And also surfactant in RDS is good for outcome. So we need to answer some questions to know exactly the basics of shock. First, we need to know what the definition of shock. Then how to classify shock. And how to monitor the predictors of shock. Shock is very bad, and it means lack of enough oxygen delivery at the tissue level. So we need to predict that from at the beginning and the early stages before it happens. And then you need to know how to treat shock, not just as empiric therapy, but based on understanding of physiology. So first, about the definition of shock. So shock is a dynamic state or dynamic and unstable pathophysiologic state characterized by inadequate tissue perfusion. So the 3 main parameters that are responsible for tissue: oxygen, blood flow, oxygen saturation, and the hemoglobin concentration. So we need to maintain the 3 of them to be sure that the tissue is getting enough oxygen. Disruption of this mechanism might end in a state of shock. Although if the perfusion impaired, because today we are focusing on the perfusion, that might be reversible, but prolonged tissue hypoxia might disrupt biochemical processes and might lead to cellular death and end organ dysfunction. So we need to avoid that. Then we need to classify shock. So there is 2 simple classification of shock. Classification based on the cause, so underlying etiology. It can be related to hypovolemia due to dehydration or loss of blood. Distributive shock. So the overall volume of the blood is normal, but with abnormal distribution, like in vasodilator shock. with the significant vasodilatation, and then the blood distributed more intravascular and more not getting enough into the tissue level. Cardiogenic shock due to arrhythmia or cardiomyopathy, or obstructive shock if there is an anatomical obstruction to the outflow from the left ventricle or the right ventricle, so there is not enough stroke volume getting into the body. But we have also the physiologic classification of shock, which is based on the underlying physiology, and we'll focus today on this classification. So based on the underlying physiology, we can classify shock into vasodilator shock or vasodilator physiology, which is the most common type of shock in neonatal age. It could be vasoconstrictive physiology, which is less common but present, and the least or the most common mechanism to be missed or underdiagnosed. Cardiogenic shock, which could be arrhythmia or cardiomyopathy or impaired myocardial performance due to prematurity or due to high vascular resistance, which is secondary to vasoconstrictive physiology. So vasoconstrictive shock might lead to cardiogenic shock. And then shunt physiology, if you have infant with left-right stealing of blood through the PDA, that might actually lead to shock. And then we need to answer how to monitor predictors of shock. So we'll focus mainly on the blood pressure, how to analyze and how to understand the blood pressure in a physiologic way, and how to treat shock. We have in practice, any practice in medicine, like pediatrics, neonatology, or adult, 3 different ways of practice, either to practice based on the evidence or practice based on the underlying physiology if we don't have the answer from evidence, or empirical management. Unfortunately, from evidence, we don't have answer for everything we practice every day. Every day during round, you may ask a few questions, and you need a clear answer for the question to continue management of neonates. So in kind of stable babies level 2, you may ask 1 to 3 questions, and you may ask 4 to 6 average questions in more sick babies. And we cannot get the answer clearly from evidence for more than 15% of the questions. And unfortunately, we left really huge number of questions not answered. And I mean by evidence, very clear answer from the evidence with very high quality, yes or no answer. For example, surfactant for RDS, nitric oxide is good for pulmonary hypertension, or caffeine for apnea of prematurity. We have very specific pathophysiology, and we have a medication that's specific for that disease. And we have a lot of other conditions that we don't have a clear answer, including management of shock. And the empirical management, I will just give you example of that. If you have a preterm infant, 26 weeks or 18 days old, developed hypotension followed by lactic acidosis, so typical shock. You started him on dopamine of 5 mics per kg per minute, and then you consider to add, to increase dopamine to 10 and add dobutamine of 5, both of them reach 20, and there is no improvement. You just keep adding medication over medication until you reach to the point that you have to ask someone to do an echo. So we asked a pediatric cardiologist to help, and he told you that there is no any issue with the heart, and the heart is working well. So you continue adding more medication. You added epinephrine, you reach up to 0.5, which is very high dose. It's equivalent to 50 mics per kg per minute of dopamine. And then the infant started to show irreversible shock. There is no improvement and almost dying. So this kind of empirical, and not actually the typical empirical management that it should be empirical. Empirical means you try one management strategy or one medication. If the medication does not work, you have to discontinue and start another medication, not just keep adding medication over medication. And at the end, you will not get any benefit, and you just get the side effects of these medications. So we need to get to move away from that and to focus on the physiologic approach to understand what the underlying pathophysiologic mechanism of shock. What about evidence? Do we have evidence? As I mentioned, evidence does not answer all of the question. And regarding shock, one of the studies, so many studies, and this study is one of them. This study was done in the Neonatal Research Network in USA and conducted among 16 different units in USA. And they studied 15 different definitions of hypotension. Hypotension means mean blood pressure less than 30, mean blood pressure less than gestational age, systolic blood pressure less than the fifth centile, and so on. 15 different definitions. And they could not answer the question. So just read the statement with you. Antihypotensive therapy administration was not associated with improved in hospital outcomes for any of the 15 definitions. Regarding the short-term outcomes, improved blood pressure, improved lactic acidosis, or long-term outcomes, neurodevelopmental outcomes, chronic lung disease, and so on. None of the 15 definitions, management based on the definition, was associated with improved any outcome. Alternative methods of deciding who to treat are needed to maximize patient benefit and minimize harm. So the alternative method makes sense to be the physiologic approach. We don't have any answer from randomized controlled trials. In shock, we have very heterogeneity of the underlying cause. We have multiple causes, and it's impossible to randomize to so many arms to get the answer at the end. Randomized controlled trials is more suitable for very simple question and yes or no. So surfactant to give or not to give for RDS and so on. So let us go through the physiology of blood pressure. We have diastolic blood pressure, and the diastolic blood pressure means one of two things. So it is reflective mainly of the vascular system, not the heart performance. Diastolic blood pressure is reflective of the systemic vascular resistance and the blood volume, what's contained in the vascular compartment. So the resistance and the blood volume. Both of them will make the diastolic blood pressure, which is the lowest detected blood pressure in the arterial side. And then the heart should contract to create a pressure above the diastolic pressure, and this pressure should be enough to eject adequate stroke volume. And this pressure is not the systolic pressure, it is a pulse pressure. And the pulse pressure is equal to the heart performance and the ability of the heart to eject the stroke volume out of the heart. Systolic pressure is a sum of both, the systolic pressure and the pulse pressure together. So that's, to some extent, misunderstanding of the systolic pressure. Systolic pressure is not equal to the heart performance. It is equal to both the systolic pressure and the pulse pressure. What is really reflective of the heart performance is the pulse pressure. And the pulse pressure is equivalent to the stroke volume, but if you multiply the stroke volume by heart rate, you will get the cardiac output, which is the heart performance in 1 minute. Based on that, we can classify easily the shock physiologically into 4 main categories: vasodilator shock, vasoconstrictor shock, or physiology, cardiogenic shock, and shunt physiology. So let us discuss one by one. If you have diastolic blood pressure decreased, so we have low diastolic blood pressure, and as I mentioned, diastolic blood pressure is reflective of systemic vascular resistance. So if the resistance decreased, it means it could be vasodilator physiology, which is very common in septic shock, for example. Pulse pressure might will stay normal or might increase a little bit. So in this situation, you have low diastolic pressure and normal or a little bit higher than normal pulse pressure. Systolic pressure will drop a little bit because, again, it is reflective of both diastolic and pulse pressure. And what about cardiac output might increase, because in this situation, in this physiology, you may have hyperdynamic heart and the higher cardiac output than expected. So this is the category number 1 of shock, or vasodilator shock. The common causes of vasodilator shock is septic shock or systemic inflammation like necrotizing enterocolitis, late onset shock, so late stages of vasodilator shock, late onset shock in premature infants due to suprarenal dysfunction. that might be resistant to vasopressors. So you may need to check the cortisol level and give hydrocortisone in this situation. And it mimic typically septic shock, but with negative blood culture. Medications like dobutamine or Marinon might actually induce hypotension. Morphine as well, anesthesia. Post-anesthesia, you may need to start on vasopressors because of the vasodilator effect from anesthesia, especially in premature babies. Acidosis, either respiratory and metabolic, actually might also induce vasodilator shock. HIE might be presented also with vasodilator shock. HIE might be presented with vasoconstrictive physiology, cardiogenic shock, or vasodilator shock, any one of them. Like in this example here, you have the invasive blood pressure monitoring, continuous blood pressure monitoring. You have the 3 lines, diastolic blood pressure in the bottom, mean blood pressure in the middle, and then systolic blood pressure. And the red area is the pulse pressure. And you can see the trend of the blood pressure is dropping. So if you see the trend is dropping, and if you started to see also oliguria or lactic acidosis, then it is a significant vasodilator shock with maintained pulse pressure. And you can see here, just after a start of vasopressor, small dose of vasopressor, you don't have to give any troops in this situation. It's contraindicated to give vasodilator like dobutamine. So once you give vasopressor, you see immediately improved blood pressure. So that's a vasodilator shock. Let us discuss the second type, which is vasoconstrictive physiology. Less common, but one of the least, one of the most underdiagnosed or the missed cases in neonatology. And fortunately, it is uncommon. So in this situation, you may have high diastolic blood pressure, normal or high diastolic pressure with narrow pulse pressure. Pulse pressure, usually it is 10 to 15 during the first day of life in premature babies, and then increase gradually 15 to 20 and should be beyond 20 beyond the postnatal transition in preterm and term babies. If you have pulse pressure less than 10, that's definitely low. In this situation, you have the systolic blood pressure also drop, and the cardiac output less than normal. And in this situation, you may see the pulse pressure narrow, and the mean blood pressure normal, systolic blood pressure might be normal, mean blood pressure normal. So if you look at each single parameter of the blood pressure, it could be normal. The only thing that you pick up this case by looking at the pulse pressure, very narrowing of the pulse pressure. This infant stayed with lactic acidosis many hours because the bedside team, they missed to look at the pulse pressure. And you can look at the pulse pressure here, 47 systolic over 39 diastolic, pulse pressure is just 8 millimeter mercury in this 1 week infant born a 30-weeker with significant pulmonary hypertension. So the vasoconstrictive physiology might happen commonly in infants with pulmonary hypertension. It's also common in failure of postnatal adaptation, especially in premature babies after separation of the placenta, which is vasodilator media. The resistance might increase and the heart might not be ready enough to contract against the increased resistance. Post-PD ligation due to sudden increase in resistance, post-AV malformation embolization, similar physiology to post-PD ligation, pulmonary hypertension or HIE. The common medication to be used here is a vasodilator. Doesn't make sense to add any vasoconstrictor or vasopressor. You need to add vasodilator with inotropic effect, like Marinon or dobutamine. Next physiology is a cardiogenic shock. In this case, you have everything low. Low diastolic, low pulse pressure, low systolic, everything low, low cardiac output. And if you look at the trend of the blood pressure, invasive blood pressure, you can see drop of everything and narrowing of the pulse pressure. In this situation, if you wait more hours, this infant might die from irreversible shock. So just shortly after start of small dose of epinephrine, here you can see the pulse pressure started to widen and the blood pressure improved. It is common in low prelude. That's why it's very important in cardiogenic shock to evaluate the heart filling by echo, failure of postnatal adaptation in preterm, pulmonary hypertension, also common in myocardial dysfunction, mechanical ventilation due to high mean air pressure, And if the mean air pressure is high enough to decrease the venous return, the physiology might be similar to the, or the blood pressure tracing might be similar to this case here. Progressive acidosis, overdose of inotropes, one of the most common cause of cardiogenic physiology in centers or colleagues who are still relying on empiric therapy, adding medication over medication on high dose of inotropes, you may get the same picture, not because of worsening of shock, because of the medication that you keep adding over and over, and at the end you get the heart feeling impaired and the heart tired from keep adding these medications. And then the last physiology is easy to diagnose by echo, which is the shunt physiology. In this situation, you have low diastolic pressure, wide pulse pressure, and slightly increased systolic pressure. So wide pulse pressure is low diastolic blood pressure in presence of confirmed PDA by echo. And also you may see increased cardiac output. This case is consistent with the shunt physiology. Now, just to summarize everything in one slide, if we have the diastolic blood pressure on one side and pulse pressure on the other side, we can categorize easily in this graph here. Just to go a little bit quickly, you can look at the blood pressure. If the diastolic blood pressure is high, so you have high diastolic blood pressure, and narrow pulse pressure, then you have the vasoconstrictive physiology. So narrow pulse pressure was high diastolic pressure, blood pressure, or at least to normal or high normal. So you have the vasoconstrictive physiology. And as we described before, the causes. If you have in this arm here, you have the high pulse pressure, so high pulse pressure with low diastolic blood pressure, that could be shunt physiology. If you have low, so you have low, and go to the left side, low diastolic blood pressure, so this is a vasodilator physiology. But if you have everything, low pulse pressure and low diastolic blood pressure, low systolic blood pressure, low everything, including low pulse pressure, which is reflective of cardiac performance, then it is more consistent with cardiogenic shock. You need to do echo in this case. It's very difficult to diagnose without echocardiography. Then we can summarize a logical selection of cardiovascular support based on the underlying physiology. So if you have infant with vasodilator physiology, then the makes sense medication to start with vasopressor, like vasopressin or norepinephrine. Again, the most common physiology in neonatal age is vasodilator shock. You will see that more than any other type of physiology. That's why it makes sense for the most common medication to be used or to be selected as a first medication to be the vasopressor, not the inotrope. So vasopressor here in this situation, you have the medication which is working mainly in the vascular compartment as a pressor, vasopressin or norepinephrine. There is no rule for fluids in this case, and you can manage this case without echo, as far as you have normal pulse pressure. But if you have a situation that normal pulse pressure and impression of cardiogenic shock, then you may need to use vasopressor with inotropic support like dopamine or epinephrine in this case. If there is no good improvement from the initial doses, then you need to ask for echocardiography. And then you may consider fluids or steroids if there is no improvement, if there is suspicion of fluid loss, or there is no improvement from vasopressors or inotropes. You may try one bolus of normal saline bolus. If there is no improvement, it means that there is no any value to continue giving more boluses. Steroids can be considered also in resistant cases, or if there is confirmation of suprarenal dysfunction by considering low cortisol level, and the cortisol level is lower than expected for normal stressed baby. We are relying on 350 millimole as a cut limit to consider hydrocortisone in resistant cases. Or you may consider in vasoconstrictive physiology a vasodilator with an inotropic effect like dobutamine or merinone. Merinone is a medication preferred to be used in echo is mandatory in this case because you need to evaluate the filling of the heart before giving any troops. Any troops might improve the systolic performance on expense of diastolic filling. So the filling might be impaired with adding more inotropes. Now we started the medication, we need to know how to wean. So we have the table, the centile table for the blood pressure. We are not considering any more mean blood pressure equal to gestational age. That's kind of 7-8 years old practice in our center. We have the centile curve for different gestational ages. For example, we have this infant with 25 weeks, and he's on medication. We need to wean the medication. So we need to look at the centile. If the blood pressure between the 5th and the 50th centile between the lowest and mean for systolic, diastolic and mean, then we can consider weaning. If the blood pressure higher than the mean for systolic, higher than the mean diastolic and for the mean, then we may or should consider weaning. So consider weaning gradual if the blood pressure between the lowest and mean, and you have to consider, or you should start weaning if the blood pressure higher than the mean. So to minimize the period of exposure to all of these dangerous medications. I'll just give you one case scenario. We have HIE infant, term infant, outborn, missed, so born outside the hospital, missed to be on cooling because came late to the hospital beyond 6 hours window of the cooling protocol. Low urine output, lactic acid of 6 started to increase. Look at the blood pressure here. If you look at the mean blood pressure only, you may consider that as normal. But if you look at the systolic and the diastolic, you can realize easily that the pulse pressure is very narrow, just 8 millimeter mercury. And you look at the trend here, very narrow pulse pressure. The 3 blood pressure lines almost merge together. So the makes sense medication, or the makes sense physiology in this case, vasoconstrictive physiology. And the medication to make sense in this case, dobutamine, not dopamine or epinephrine, dobutamine. And this infant is improved with just a small dose of dobutamine. If you don't have invasive blood pressure in your unit, you may consider frequent assessment of non-invasive blood pressure by cuff and follow the trend. You just draw a line over the trend, the upper limit and lower limit, and look at the trend. If the trend is trending down, as you can see here, and if that is associated with low urine output, you have to consider support. In this infant, the support was epinephrine, and the blood pressure improved with the widening of the pulse pressure immediately after a small dose of epinephrine. You may consider other indicators of shock other than blood pressure, but they are non-specific and very subjective, and there is a lot of confounding factors in each one of them. So you may look at the capillary refill time, which might be affected by like you have wide range of normal. There is no consensus of what's normal for that. Pallor, which might be also associated with anemia, decreased level of consciousness, urine output, lactic acidosis. I may consider lactic acidosis, urine output, level of consciousness, the most important 3 other parameters as reflective of shock, together with the blood pressure. Then, if you have unresponsiveness to cardiovascular support, you start on one medication, and then there is no response. You have to consider that could be a wrong medication, and you may need to change, not to keep add-on medication over medication. It changes the medication with another one and reassess for responsiveness. And always think about the underlying physiology. It could be high dose of inotropes, one of the most common reasons for worsening of shock. High dose of inotropes. I show you the echocardiography here for this infant. This 4-chamber view of the heart with almost empty heart. There is almost no blood flow in the heart. Just the heart is contracting, empty. This infant was on dopamine of 15, dobutamine of 20, epinephrine of 1 mic. That's extremely high dose. And what we did in this case, we just discontinued everything. And the infant improved just with the discontinuation, one medication after the other. And the echo, 24 hours later, you can see improvement. The heart is contracting with good filling without any issue, and the urine output improved. So in some situation, you need to wean the medication. That could be the reason of worsening. not just keep adding medication without understanding the underlying physiology. So in this situation, you just have to wean or discontinue the medication if you are keep adding medication and there is no any improvement. It could be suprarenal dysfunction. In this situation, you may consider adding steroids, or you may consider also echocardiography to rule out any underlying or missed cardiac pathology. It could be undiagnosed coarctation or other pathology. So if the echo not considered, you have to consider that at that time if there is no improvement. So you may ask me what's the evidence behind the physiologic approach. In our center, we compared the integrated approach. In our model, we are integrating the physiologic approach of clinical assessment together with echocardiography, sometimes with a tissue oxygenation by near-field spectroscopy. So we do this integrated model for last 6 years. So we compared the 3 years of implementation with the 3 years before we implemented this model. And the result or the conclusion was, with implementing the physiologic approach, you can minimize exposure to cardiovascular medication. So in our model or our research, we studied 340 assessed in 2 epochs. Epoch before implementation of the integrated approach, and the second epoch after implementation. The time to clinical recovery, 50% less to the time to clinical recovery in the first epoch with the more empiric approach, with much less doses and much less overall vasoactive inotropic score. So the overall amount of medication much less compared to the first epoch. Less number of deaths, but overall number is very low to assess the mortality as outcome in this research. And to conclude in my presentation, look at the trend before and after intervention. So look at the blood pressure not just at one longitudinal time, look at the trend over time. If the trend is going down significantly, then you have to intervene. And when you consider intervention, you have to look at the trend after that. If there is no improvement, you have to revise your strategy. Compare the values to the normalized centile curves of post-menstrual age for the blood pressure. So there is no evidence supporting the idea of mean blood pressure equal to gestational age, which is common practice, not supported by evidence, unfortunately still adopted in a lot of centers. Change your formulated recommendation if there is no improvement after 1 to 2 hours. So don't wait long time if there is no improvement. Reassess the situation and consider to change your strategy if there is no improvement in short time. Physiologic approach is proven to be safer and effective compared to empirical management. Based on our study, and there's a lot of other studies in other centers proving the importance of relying on physiologic approach, either clinical physiologic approach or clinical plus advanced assessment with a targeted neonatal echocardiography. So this is the end of my presentation. Thank you for listening, and happy to have your questions.